Evening, everyone who's present here, and a warm welcome. Sir, Vijay Sir, President CAHO, Mr. Samir Mehta, Vice President, Dr. Lalu Joseph, the Secretary General, and the members of the Governing Council, CAHO, and the distinguished panelists from various hospitals across the country. On behalf of CAHO, I welcome you all for the first CAHO Healthcare CXO Roundtable meeting, and a warm greetings from CAHO once again. We thank you for accepting our invitation to be part of the CAHO Healthcare CXO Roundtable. This is an initiative of the Healthcare Institution Division of CAHO, which will bring together leaders in the healthcare to share their experiences, strategies adopted while facing unprecedented situations in their hospital and any other challenges in providing healthcare. The first roundtable discussion is on the sharing leadership strategies during the COVID crisis. This was actually the brainwave of our President Vijay sir. Last week actually said we should do something, a discussion on roundtable of all the leaders, healthcare leaders in the country, and they went through this crisis. So we need to understand what kind of situation they faced and how to understand the challenges and see whether we can come out with the possible solutions which we can adopt in the future period. So as I said, the country is currently reeling under the second wave of COVID-19 pandemic. Our healthcare infrastructure is stretched beyond limits, resulting in many unavoidable deaths. Pertinent discussions now are necessary at this point of time, with the hope that these may help in dispassionate analysis and provide learnings for the future. In this direction, we would like you to share your experience of overcoming the recent crisis, challenges, and explore prospects for the future in managing COVID in the country, which will be a motivation for others at the forefront to fight against COVID. So we have distinguished panelists of chief executives of various hospitals in the country. So it will be my privilege to introduce them before we start the discussion. Firstly, we have Dr. Sunil Kumar Sagar, CEO of Shanti Mukund Hospital, Delhi. Dr. Upasana Arora, Director, Yashoda Super Speciality Hospital, Delhi. Dr. C.M. Bhagat, Director, Bhagat Hospitals, New Delhi. Dr. Vishnu Panigrahi, Group Head Medical Strategy and Operations, Fortis Healthcare, Delhi. Dr. Prashant Rajgopalan, Director, MGM Healthcare, Chennai. Dr. Ila Kumaran, CEO, Rela Institute of Medical Center, Chennai. Dr. Arun Palaniswami, Executive Director, Kovai Medical Center and Hospital, Coimbatore. Dr. Rupak Barua, CEO, AMRI Hospitals, Calcutta. Mrs. Kamalika Datta, Desun Hospital and Heart Institute, Calcutta. Ms. Ipsita Kundu, CEO, Charnock Hospitals, Calcutta. Dr. Shakti Mohapatra, Group Medical Director, Sahadri Group of Hospitals, Pune. Dr. Dilip Singh Chauhan, Deputy Medical Director, Medical Services, Bombay Hospital, Indore. Ms. Ikta Modi, COO, Parul Shevashram Hospital, Baroda. Dr. Tushar Vijay Gawad, Director Administration, Alexis Hospital, Nagpur. Dr. K. Arish, Vice Principal and Associate Dean, Ramaya Medical College Hospital, Bangalore. Dr. Colonel M. Dayananda, Director, JSS Hospital, Mysore. Dr. Nagasubramaniam, Facility Director, Fortis Hospital, Bangalore. Dr. Prasanna HM, Chairman and Managing Director, Pristine Hospital, Bangalore, and also is the President of the Private Hospital and Nursing Home Association, Karnataka. Dr. Sandeep D'Souza, COO and Director, Medical Services, People Tree Hospital, Bangalore. And Dr. Srinivas M, CEO, Prakriya Hospital, Bangalore. So before we start the discussions on the topic, I would request our President, Dr. Vijay Agarwal, to have introductory remarks. Sir, over to you, sir.
Good evening, and thank you, Dr. Narendranath, for this wonderful initiative that you have given shape to, I will say. And thank you to each one of the senior, I would say, functionaries of our healthcare fraternity, which have assembled here today. It's really a dream come true for CAHO in the sense that we have been wanting to have a kind of a forum where we can deliberate or discuss amongst the CEOs and the CEOs of the hospitals to, in fact, take this ship of CAHO forward and to understand from you, because eventually this organization is nothing but some part of you is there in the organization. Whatever you are doing in the hospital, we want that whatever are the good things that should be shared with other people so that we all together can be in this journey of continuous quality improvement. And the only way would be for us to put our hearts and minds together. And I thought that no other better time than this pandemic, which has made us see, I think, one of the most trying times of our life. I can say that I'm almost now 75 years and I have never ever seen this kind of a catastrophe in any field, in the sense that, of course, medically it is affecting us the most. And I think over the last almost now more than a year, we have been tested, but in the last 3 months, it has really gone to another limit. So I think as people who are running the hospitals, I know that whether it is a problem of getting beds, whether it is a problem of getting oxygen, whether it is a problem of getting the right personnel, whether it is issues of maintenance, I think the challenges are all have stared against each one of us. But I think the stories of how your leadership has sailed us through and how we are sailing through this has not come to the fore. So I thought, number one, those stories of your unique leadership style, which can be of great amount of relevance and motivation to somebody else, should come to the forefront. As well as if you have any suggestions, whether the suggestions can be for how do people coming together can help, how can an organization like us can do, or what can the government do so that we can become the voice, even with our sister organizations like AHPI and all that, to take those thought processes in that direction. So I will say that I'm really looking forward to hearing each one of you, and over to you, Narendranath and Lalu, to take the discussion forward, please. Thank you.
Thank you, sir. Thank you for your motivating words. It would be definitely this kind of meetings is going to be on a regular basis, and definitely we want to bring the leaders in the healthcare on this forum and platform so that we can learn a lot from them and also bring possible solution throughout the country. So the idea is that we have selected about 20 panelists across the country where there were major crises. The most, I think, the burden was on Delhi, Mumbai, Chennai, Bangalore, and Calcutta. So this is where the composition, people are coming from 5 different cities of the country, and where the maximum problem was there. So, so we have not kept any structured kind of presentations or meeting. What we have tried to put is some kind of questions. I think Dr. Lalu and me put in some list of questions. Dr. Lalu will start the questions and this one, and later it can be open for comments from any one of the panelists. So we want you to be more open about and raise comment, give the right comment and solutions. And I'll invite Dr. Lalu to take the lead. Madam, over to you first.
Thank you, Naren sir, and welcome all of you. This is a very informal meeting. Let's put it that way. It's like having coffee together virtually. That's how it is going to be. So it's not a very structured presentation or anything that you're going to make. So let's all share our experiences. And you must all be having unique leadership styles that you have exhibited as leaders in managing situations. And this is the first series that we are doing, and congratulations to the hospital wing, the healthcare division wing of CAHO. We have three wings: the healthcare division, quality professionals, and the diagnostic group. The three leaders are here with us: Dr. Narendranath, who heads the hospital wing. We have Dr. Anuradha, who heads the the quality professionals wing, and we have Dr. Seema Bhargav, who heads the diagnostics wing. So CAHO has actually grown leaps and bounds, but we really thought it's a great opportunity for us to get the healthcare leaders together. So this is a very informal forum, and every month we are going to be having different leaders discussing various aspects of care and leadership styles. So we thought we'll keep it as informal as possible. So don't hesitate to share anything. And we have a person with us, Mr. Shanu, who will be recording, in the sense, he'll be putting that down. With your consent, then we will put it down in paper. Otherwise, it will not be published or anything. So let's just have a very informal, open discussion. So as you went through this crisis, particularly those in Delhi, it was really heartbreaking to see the kind of oxygen crisis that you all went through in Delhi. And we also saw Dr. Sunil Sagar almost breaking down, in the media. Honestly, I shed tears, sir. And I wrote to you also. It was really heartbreaking. So it must have been a very difficult situation as a leader, facing that in the forefront. So what we want to listen from you is, how was it as a leader to face that? And in a short span of about 2 to 3 minutes, if you can explain, how did you manage this crisis? Of course, you went on to the media, but that's also a strategy. So, what is it that you learned, and what kind of a leadership style did you exhibit? And do you think you would have done it better? So, if we can listen to you, sir.
I think, thank you very much. When I broke down before the media or before whatever, is actually the actual presentation or actually what was doing in my mind. We are supposed to give life, and we could not give oxygen. If we can't oxygen and patient dies, it is not dying because skills were not there, infrastructure was not there, logistics were not there, oxygen was not. Such a bad thing, right? And then the oxygen people, the government, insensitive drug trade, infected people, they keep on telling you fill this form, fill that form, report within half an hour. And I had been very active with the help of AHPI and other people, even not hesitating going to the court and getting the orders in a day. Fine. When this thing happened, this happened on 24th of April. Fine. I had 110 patients, and the oxygen stock was only till about 7 o'clock. And if I don't get oxygen, and you see, Shantimganj Hospital is nowhere in the map of Indian healthcare. It's a small hospital doing to do good things, trying to come up, trying to expand. But even in my earlier years, we installed our own oxygen generator, which was giving me 31 D-type oxygen cylinders. Then we added another 31. Then last year added another 62 cylinders, so 125 D-type cylinder bar. That is 1,250 kg of oxygen. And suddenly they come up, say, your supplier is changed. I think this is just totally a brainless thing. Normally, when I buy, I choose a vendor. They say, no, you from Linde, not from Inox. When I talk to Inox, they say, we cannot give you. When Linde, they say, orders we have not received. On the top of it, my oxygen from that day, oxygen was to be supplied by Inox only. And they say, आपके पास ऑक्सीजन आ जाएगी पर रात को 10 बजे आएगी. मैं 7 बजे से लेकर 10 बजे तक पेशेंट को मैं क्या खिलाऊं? पानी पिलाऊंगा ऑक्सीजन की तरह दे. Then ultimately the whole thing about 225, I thought of mobilizing, writing to CM, writing to everybody. If the patient dies, they will be on your head, and Sometimes, I treat myself as a very blessed person. I just thought to my mind, I spoke to the health minister that if you don't do this, then if that happens, then it will be a charge of murder on you. The moment I use this word, that the whole thing got sensitized. You believe me, I'm telling you honestly, if at 4 o'clock, 4:30, the chief secretary, because the oxygen plant where the oxygen gets supplied to me is at Modi Nagar. Fine, and I'm at Delhi. There are two governments which are involved. Therefore, even if they start from at 4 p.m. And ultimately the tanker there was empty, they will take some time before it filled up. Then a green corridor was created where the chief secretary of UP and the lieutenant governor and all those people, and a green corridor was created. A green corridor. Then I expressed my fear. If you do this, and in the meantime, my oxygen tanker will be hijacked. They said, yes, we agree with you because there's a lot of problem and drivers can be tied. Then I said, okay, one is that will be hacked, and secondly, the tanker can break down. You will see 110 dead bodies, I said. They said, no, we'll ensure. I said, no, if the oxygen doesn't reach by 7 o'clock, you will see 110 dead bodies. They provided another, towaway tanker. They said another thing. And will believe you, I have the videos available with me. When the oxygen tanker moved from Modi Nagar to Shanti Mukund Hospital at Kadkaduma in 1 hour, 50 minutes, and it moved as if the Prime Minister's cavalcade is going on. The DCP, the DSP, all things, people in the escort vehicle and all those things. This is something. I'm sorry. I am a guardian of all those patients, those who come to my organization. They look at us. It is not that it is whims and fancies of the government, they will do it. And after that, every day, believe you me, now the people, they ask me, are you getting sufficient oxygen? They know this person is capable, who can speak out. No, who has experience of dealing with COVID? Even till today, we could not decide it is a virus or it is a bacteria. Every day you come up with this, first vaccination 28 days, then 42 days, then 3 weeks, then 6 weeks. You do not know. Then why the hell you are opening? You let us do the thing. You tell us, fill up this form in 2 hours time, otherwise legal action will be taken. Hang us. What does it mean? I should treat my patient, or should I say that fill the form? My nurses, my doctors, they are falling sick, they are getting inflicted. Every institution must be feeling like this one.
Exactly. I think your emotions are well taken, Sunil sir. But the most important learning out of this, as a leader, I think you actually brought out the right point at the right time. Probably if you didn't, you were not scared to bring out, you were not scared of the media, or you were not scared of the politicians or anybody, that you voiced it out. And that's probably really helped create the green corridor.
Please appreciate, I myself was inflicted by COVID and I was sitting in the hospital.
Yes, sir. Yes, sir.
My MS got inflicted. We all were sitting. We just wanted to show, not only show, but actually prove that, yes, by being in COVID does not mean your brain doesn't work. You cannot take action. You can be isolation. We are doing this meeting. Are we sitting physically? Is something preventing me? Why did I choose healthcare?
Yeah.
I should have gone elsewhere.
Yes, certainly we appreciate the emotions. I think all of us are going through the same emotions, Sunil sir. Thank you very much.
Nobody has experience, but at least whatever we are trying to do, help us.
Yes.
We incentivize our people. Lot of money is spent on, crores and crores of money is being spent on, on this. It is so irritating. You want to make a call to your doctor or to your otherwise, for 35 seconds, you let the corona vaccine lagaiye.
Yes. Sir, Sunil sir, I think...
Just give me 1 minute, because this is important.
Yes,
most of my colleagues, my people, they might not be knowing. There's a government scheme that if you are a healthcare worker, whether ward boy, whether doctor, whether nurse or anything, and if you are directly involved in a COVID duty, you get inflicted and you die, and the cause of that death can be directly attributed to the COVID. Government of India gives 50 lakhs of rupees. This is not being circulated. This is not, this is authentic.
Yes, certainly, sir. We are
Sir.
completely aware. Yes, we appreciate the emotions because I think all of us are really going through this. And what we have taken from you is to probably speak out at the right time and not to hesitate, not to feel shy about speaking out, but yes, to speak out. And that's a very important leadership quality.
This oxygen was a serious issue all over the country. And I don't know why it suddenly came up at the same time throughout the country. Can we take some feedback from different regions? Anybody from Mumbai can talk about the oxygen issue?
Mumbai, I don't know if they really went through the
Only
crisis.
Dr. Rajkumar Patil is there. I think sir can
Yeah,
speak.
yeah. Good evening, everybody. Mumbai, some of the hospitals, smaller hospitals, have faced this one oxygen problem, but by and large, the larger hospitals have their own facility, and they had stocked up the oxygen supplies. For example, we used to get the supply regularly from Linde, so we have not faced the crisis as such in our hospital. And even for ventilator patients and for HFNCs also, we have been using that. But at the directorate level, there was a meeting with the government saying that conserve the oxygen usage in your patients. They advocated not to use the HFNCs because they are consuming a lot of oxygen supplies. As compared to one ventilator, the four ventilator supplies, the one HFNC machine was taking the oxygen supply. So that was the consensus decision in government of Maharashtra, which we made throughout the state. But so in the peripheral hospitals, we are facing the definitely the oxygen crisis was there. So this is what we have gone through. But Mumbai city as such, we have been able to maintain the supply.
Manage it.
Manage the supply, yes.
Anybody from the eastern region? Can I request Ipsita is around? Madam, can you comment on this issue of oxygen?
Good evening, sir. Good evening. Oxygen, yes, it was definitely a very serious issue. But for us personally, we could manage through. Moreover, we have also opened a separate unit for treating COVID patients not near the main hospital. There also we have been able to manage things properly. We are having liquid oxygen plants there. But yes, I have heard that there are people, the smaller nursing homes or smaller hospitals who have faced this crisis. And government had tried to help them out. That's what also has to be mentioned.
Okay, so it's seen that the bigger hospitals didn't have much of oxygen issue, but it's all in the smaller hospitals.
Right, sir.
Can I butt in, Narendra? Can I just say something?
Yes.
Sir, please, sir.
So, you see, I think together we need to today analyze that which hospitals received the industrial oxygen, which hospitals used some kind of oxygen plants which came from outside, etc., whatever. You see, now we need to know also in terms of efficacy. For example, just an hour back, we were talking to Lalu, and one of the theories that has been going around is that this issue of mucormycosis or the black fungus, is it linked to, what part is it linked to? Of course, the indiscriminate use of steroids, but it has been seen in many countries. But is it our industrial oxygen that could be responsible for it? So issue is this, that now we need data. And therefore, if even now, we'll probably just do a survey on the oxygen issue. If Sakshi can just send a kind of a questionnaire, and you have to just say that, all right, how did you manage your oxygen crisis? With industrial oxygen, you had your regular supply, you had oxygen concentrator. I think that together we may be able to shed some light on these issues, and they are not coming to the forefront because we don't have the data. I think if Lalu can take this forward, that will be good, because that's how everybody's view on oxygen will start making sense for me for future. And very soon, we will also have a webinar where we may talk about all possible sources of oxygen, its economics, and which one makes sense, which does not make sense. So this is how I think we need to make this, this input from this forum will be extremely useful.
Absolutely. I think Dr. Harish
Can I just make one point?
Dr. Shankar, I think Dr. Harish has a point. Yes, over to you, Dr. Harish.
We had a peculiar problem in our hospital. See, there was no problem with the supply. We have an oxygen plant which supplies us, which is a storage capacity of 20,000 kiloliters. But the problem was last year when the COVID epidemic happened, we centrally oxygenated all the beds, almost all the beds. 700 of the 800 beds were oxygenated. We drew the central lines. So last year, the peak was about 375 in our hospital, and we didn't have much of a problem. This time, when the admissions increased, we suddenly noticed on 1st of May, a decrease of pressure in the ICU. Usually they say around 4 bar is the pressure required in the ICU. It came down to 2.75 or 3 bar. And we wrote a letter to the commissioner of Bangalore stating that we need to hold on to admissions because of this issue. Finally, we called the Praxair people and we set it right, putting a second vaporizer. And after that, for the last 10 days, it's all right. But this was a peculiar problem, which when we spoke to Praxair, they told that they didn't have an experience where an entire hospital like this was oxygenated, and they were not sure that the pressure would be set right, even if they put a second vaporizer. And fortunately, we got it set right. Just wanted to share that experience.
I think that's brilliant. This is the typical example of doing a proper root cause analysis and trying to understand what it is at the right time. Because yes, sir, with the increased load, certainly the pressures can come down. And yes, Dr. Shankar, for your points.
Actually, 2 points I just want to add. One is that already Harish has already told. This happened to our hospital also, which has got a, state government, COVID setup, and where we had a liquid oxygen plant and everything, but suddenly because of the lot of HFNOs were running, and suddenly pressure dropped. So that was something which was later on corrected. So this is some problem which can happen to any hospital. Other point which I want to make it to be noted, that in most of the major cities, what happened in the first phase of the second wave, that is the people are not getting the hospital beds and people are dying at home. I have lost one of my friends who is just 52 years old of my age, and you know that this person was kept on oxygen at home, and we are planning to shift him next day morning to a hospital, and in between time suddenly oxygen got finished and his saturation came down. That by 2 hours time when we reached him to a hospital, nearby hospital, by the time he was told that he is brought dead. So this happens to every metro city. Now all the major hospital didn't have the problem. You have to think over and also channelize your planning about the home care setup and the people who are staying as a home quarantine, the oxygen supply to them, and how judiciously you can use the oxygen supply to those people who really need when they're not getting the hospital bed immediately. That is what I want to be noted.
Absolutely. It's a very valid point. That brings us to a very important component of not just putting them on home isolation, but the kind of follow-up on the home isolation and the supplies to them. You know, if they are linked to our hospitals, then they automatically become, it is our liability also, because we are the ones who are actually putting them on home isolation then. So yes, that's certainly a major point.
I think Dr. Sakti Mohapatra has a point. Dr. Sakti, please go ahead.
Okay. So I just want to come here. Pune is one of the cities with highest COVID load, active cases. So we also anticipated, oxygen shortage at the peak of the, case load. So we proactively decided and we took up a program called Oxygen Stewardship, where we have the on the hand knowledge of, total oxygen consumption per day, every 6 hourly, and the replacements, because the sources of oxygen varied from hospital to hospital. So in few hospitals where the LMO was present, we have the tankers, LMO tanks, we didn't face any problems because the replacement came very early. But so few of the hospitals where we are managing with Dura cylinders or jumbo cylinders, the problem lied there. So what it taught us that we have to actually strategize with regard to the caseload of the hospital and the case mix of the hospital with, and the oxygen sources. Even if you have oxygen supply or the source of oxygen is there, but your hospital doesn't have a system to utilize it. Suppose you don't have a LMO tank, or you don't have a, or you have a Dura cylinders, but you don't get the replacements. So, so we went into all the alternatives available with us. We made a strategy. So somehow we could manage. We didn't have any SOS calls and all. But in in 2 or 3 facilities, we're having almost like 3-4 hours stock, almost like 20-25 days. So that was a little scary.
That's brilliant, sir.
Okay.
This oxygen stewardship is a very, very important concept of this overall management. And looking at it, it's a lot of wastage. And we have also realized it's almost 20% wastage. Typically, the titration doesn't happen. Patients are all kept at 98% saturation when what is required is 94 to probably 92 to 94. And the titration doesn't happen the whole day. The patients are put on high oxygen consumption, plus the terminal ends are not closed, a lot of wastage also. So that's excellent. And that brings us to a very valuable concept of measuring. And I think that's exactly what you have done. And yes, so let's listen to Dr. Vishnu and then Dr. Prasanna and then Bharati Madam. Yeah.
Thank you for the virtual coffee session with Lallu and Vijay. So I think so. A very relevant point came up about the smaller hospitals facing the oxygen shortage. I think so. Oxygen should now be taken as a drug. And if you look at one of the reasons of this mucormycosis also, still we have over the counter sale. You can go to any chemist, take whatever drug you want. So even the oxygen, if you look at it, most of the hospitals, big, small, they have tied up. They have a supply chain which is there. This got disrupted because of this panic buying of oxygen cylinders, not from hospital providers, from general public, and people started hoarding this. So this created panic, and those who had the wherewithal, who had the power, who had the influence, they managed to garner a big chunk of that. So the people where the filling is to happen, the people with the who knew the police, who knew the administration, they used to get the major chunk. So the small players, what I'm saying is the smaller hospital, nursing homes, they were deprived of this. So this is something that we need to look at. How do we sort of get this sanitized? And this pandemic happened, something more can happen later. And the other thing is also oxygen is, we should take it as a drug. So these are the two things I had in mind. I just wanted to share it.
Thanks for those thoughts, sir. Certainly, yes, because we are all large players.
And Lalu, I'll just be sharing one pager. I'll send it across to you.
Yes, yes.
Because about 4 weeks back, a Delhi government team came and they were reviewing what is the way we are managing our oxygen in our hospitals. And lo and behold, there was a one sheeter on oxygen audits in the hospital. What are the things that you should do? Because needed, I'll be maybe off the mark, but needed 20-30% is because of leakage.
Yeah.
People. So that is something. If you look at the wards and all that, there'll be patients be wearing a mask. Then suddenly they've gone to the washroom. The flow meter will still be on.
Yes. Yes.
You'll be eating something. The flow meter will still be on. So this concept of having an oxygen nurse will be moving around and seeing this. So these are things that we put in, and that the authorities were very appreciative of that. They picked up a copy and took it. So I'll share it with Dr. Gyani and the AHP team. I'll share it with you.
So that's again another leadership quality of sharing best practices. So here again we have got another leadership quality, which is, not hesitating to share with everybody. Really appreciate Vishnu sir for that. Now let's listen from Prasanna sir. Dr. Prasanna. Yeah.
Hi, good evening everyone. Bangalore also faced a lot of oxygen shortage issues, apart from Delhi, especially medium and small hospitals bore the brunt. Somehow the government was very hesitant in the beginning to help us out. They used to shout back at us, why you are not increasing your storage capacity? But the requirement went up by 5-6 folds. Nobody imagined that this much of oxygen will be required. So we somehow convinced the government to put up a war room for oxygen now. At least it has started functioning, and even the government agencies have kept some jumbo cylinders as backup whenever we have a shortage. What we did during the crisis is we converted Bangalore into 5 zones. Wherever there was a shortage, we zonally helped one another hospital. We had a filled up Dura cylinder. We used to send in a trolley immediately to the required hospital. So we shared the resources, and so many nights were spent sleeplessly. But because of the sharing, each one of us came out unscathed. We did not have a single death in Bangalore because of oxygen shortage. Second point I wanted to tell is Dr. Harish made a point about dropping pressures in ICU. This we also noticed. So now we have changed our tactic. We have dedicated line directly going to the ICU so that the pressures doesn't drop, which is very critical. And third point, Dr. Vishnu told, leakage is the biggest thing. We did an auditing of all our oxygen ports for 100 beds. We saw that almost 70 of these ports were leaking. We fixed it, and almost we could save 20% of the oxygen problem. But still, oxygen supply in Bangalore is a concern. Even now, it has not been fixed. It has been erratic. And I had to put up a affidavit in the High Court of Karnataka without any fear against the government. The High Court took the government to a very big way. They gave this one to the government. And now the government has woken up. And we need to stand up for our cause. We should not be afraid of these governments. That's what I wanted to share.
I really appreciate, sir. There are two very important points. One is standing up, and typically that's what Dr. Sunil also did. So we don't have to fear anybody. It is for a common cause of patients. We are not asking for ourselves. And that's an excellent leadership. The second important point that I want to highlight is networking. So that's what we are all here for. And that networking really helps in a crisis. And a leader certainly needs that networking, between hospitals and friends, and we don't view each other as competition or competitors. So that's certainly a very good leadership point to note from you, sir. Thank
Madam,
you.
that is one good thing coming from Dr. Prasanna.
Yeah.
Prasanna is the president of the private hospital nursing home, which is almost about 700 hospitals in Bangalore.
Brilliant.
In fact, he's front-ending the private hospitals and also interfacing with the government. In fact, the private healthcare is really providing the care to the COVID patients more than the government. In fact, Dr. Harish is almost servicing 800 patients, and all the private hospitals are given 50% of the beds for COVID, which government admits the patients.
Okay.
I think that's a good thing which Bangalore has done. And also they have fixed rate and they go by the government approved rates. That's one good thing with that.
Perfect. Thanks for that, and welcome to CAHO, all of you. This is a forum for networking. Now, to take from what Dr. Tushar has put down, yes, the oxygen, everything has escalated. We all know what we used to buy for 11 rupees is now 18 rupees per cubic meter. Any supply, anything, the rates have gone up. And now from what we heard, Karnataka has a ceiling, Tamil Nadu has a ceiling. We can't charge more than what they have fixed. So it's certainly a huge financial drain for the organization. So the question to you is, Tushar sir, what do you think? How as a leader are you able to manage this financial crisis or the deficits and yet provide good quality care? And what kind of a leadership skill are you able to exhibit at this point in time? Are you able to negotiate at all? Or what is your take?
Good evening. I'm Dr. Tushar, Director Administration, Alexis Multispecialty Hospital, Nagpur. So Nagpur did see a surge, and Nagpur was the epicenter of COVID-19, the second wave, especially which started in Maharashtra. And here there has been a capping on the rates by the government of Maharashtra for quite some time now, and that was there for COVID as well as non-COVID to begin with. So through Vidarbha Hospital Association, of which we are also a member, this was challenged in the High Court. First it was in the Supreme Court, then the Supreme Court told us to go to the High Court. And with help of Dr. Pradeep Arora, who is the legal counsel for us, we managed to quash the capping for non-COVID. The capping for COVID-19 rates is still sub judice, and we are still fighting with the administration with regards to this, because as you rightly said, the input costs have increased, but we have not been able to pass it on to the customers. So the important thing for us was to optimize the average length of stay and increase the churn of beds, because the more the number of patients we treat in the shorter span of time, that would help us in optimizing the cost and increasing our revenue. So with help of drugs available such as remdesivir, though there was a lot of controversy, what we have seen is it did help us to cut down the length of stay in the hospital by at least 2 to 3 days. And when it was available, the length of stay was say 4.5 days or 5 days. Whereas when it was not available, the length of stay went up to say 7.5 days, 8 days. So optimizing the length of stay was one thing which we did for COVID-19 patients. And apart from that, a few carefully selected COVID-19 patients, we also managed to treat on daycare basis. So we were administering remdesivir even on daycare basis with careful monitoring. And a lot of patients we have treated, and very few out of those, I would say not more than 2% of those would have required admission subsequently, in spite of we treating them on daycare basis. So these two things is what we did. And even now we are fighting the administration, because the administration is trying to interfere even in the 20% beds which are under the regulation of the hospitals, wherein the hospital can charge as per their rates, and as well as the TP insurance and the corporate patients.
No, it's certainly everywhere. That's the problem. And
Yes.
really appreciates the way you have worked around it and tried to reduce the length of stay so that more number of patients can be admitted. There are risks
Yes.
associated with that, certainly, but yes, you did address the home care part of it as well. So leadership is all about innovation and working around the system. And thanks for that wonderful demonstration. Thanks, Dr. Tushar. I think Dr. Arun Palaniswami has a take on that. Dr. Arun, over to you.
So just briefly, Coimbatore still has an oxygen problem. Our major hospitals are still facing it. One of the major issues is that a lot of our oxygen was coming from Palaka, just across the border. One of the problems we've been facing here in Coimbatore is a lot of state government interference. So luckily I was Praxia and I was getting from Chennai. My oxygen was coming supply. A lot of the other major hospitals had to be, and some of my smaller peripheral hospitals were supplied from Kerala. All of a sudden, the Kerala governor blocked the transport of liquid oxygen, and we're still into major crisis. So my two other peripheral centers, I've had to transfer all the ICU patients out with oxygen. I've had to go down to just emergency surgery, and if anyone needs heavily oxygen afterwards, I automatically transfer those patients back to my main center. This is still an ongoing crisis where now that our small hospitals are not getting enough oxygen, they're not taking any ICU case, oxygen case. So they're all dumping into the big hospitals, and it's creating a big mess. So there is a lot of problems with interference from the state government. I think the person from Maharashtra just mentioned that, remdesivir, the Maharashtrian government blocked the shipment of remdesivir to Tamil Nadu, just so you know. It's not your fault, but I'm just letting you know. So even when they saw the allocation of remdesivir, all of a sudden, like Maharashtra had like 50%, huge chunk of it compared to when the rest of the population. Partially because they couldn't get it out of Maharashtra, they had to cut some deal with the state government there. So there is a lot of political interference, which is interfering with our oxygen and medical supplies. I've heard the similar thing in masks and other supplies being transferred across borders. The other thing I wanted to bring up on oxygen was that there's a whole lot of demand for these oxygen generators. Recently, I've been looking into the legal aspects. We looked into it 2 years ago prior to COVID. There's a situation where the PSA generators were only producing about 95% oxygen, whereas the liquid does 99%. So most of the time we don't use it in any setting in ICU or thing, but when a patient gets critical, you do up to 100%. So there's a question: if someone goes into code blue and dies, and you only gave 95% instead of 100%, can you be legally sued? There's no legal protection again there. Number two, I've been talking to the manufacturers of their equipment, both ventilators and anesthesia boils apparatus, anesthesia work machines. The PSA generators are all 95 plus or minus 2. Here, there's the generators. All the ventilator companies says they're not deal to high level below 95%. There's going to be issues. And I think with the industrial oxygen and with lower generator capacity, I think Hamilton, which is, I think, for what all supply CNC Veltler says, they have to install special filters now for the next generation of machines.
Absolutely.
So there's a lot of small issues with these oxygen generators. It's not very clear cut.
Yeah, I think we now post-COVID, we are going to have a lot of solutions to these questions that you're talking about. Number one, yes, your ventilators will have to be calibrated to bring them down to probably 95, 96% because your machines actually don't work. That's the problem, the high-end ventilators. But there's no scientific evidence, I understand, that 96% oxygen is not good, it's going to give any different outcome from 99%. That's what I'm hearing. But yes, we'll have to get into all this, and without data, certainly we cannot do this. So that is why what Dr. Vijay Agarwal says is very important, that we all come together and collect as much data as possible. The second thing that you mentioned, Dr. Arun, there Kerala government stopped you. For CMC, it is Bellary. From Bellary, our oxygen tanker comes. So for us, the Karnataka government has stopped us. So we are actually functioning in a country with 31 different countries. So that's a problem. Each border is kind of closed. So this is another big difficulty for all of us. Samir has had something to say. I'm sure Samir has something to say. And after this, I'll hand over to Dr. Narendranath for the next topic on manpower crisis. Naren sir, you're ready? So let's hear from our dear friend Sam.
Yeah. Sam, please go ahead.
Thanks a lot. I actually think we should be hearing with Dr. Bhagat because he was one of the HPI oxygen specialists in this and came up with a good white paper. But look, I think this was unprecedented. Many of us in different ways dealt with it very differently. Clearly for us, we got a lot of help from many of our friends here for advice. I think Lalu, rock star, absolute rock star. A lot of folks around Tamil Nadu and Chennai shared best practices, and many of us tried to help each other. The harsh reality is that I think whatever we tried, it was like a drop in the ocean. I don't think that the responsibility of making sure oxygen is there from outside a hospital's premises to inside a hospital premises should be passed on to a clinician. Right? I think that's something that we have a point. But if you don't have a team to do this, and if your team is down, and that is also something many of us faced, that members of our team, the critical members of our teams that were down, that was something that was truly unprecedented. And I think more than anything else, a lot of future learnings rather than current. But I think the long-term solutions are very different from the short-term solutions. I mean, short terms, we were trying to reduce the number of beds so that perhaps we had a little bit more runway in terms of predicting. And that was a really shitty thing to do, right? When the number of cases is growing in your city and you're having to figure out how to reduce the number of patients you can manage in an oxygen. I mean, I had a friend's father who was rejected in 2 hospitals that we know are very good friends of CAHO and HPI because they were scared of their oxygen supply. So they did not stabilize the person's father. That person we stabilized in our hospital, even though we were stressed, but they did not survive past the night, right? Because the damage had already been done to a large extent. So I think there will be learning. I think we will have to dust ourselves off, perhaps be a lot kinder to ourselves as well over the midterm, because this was something that not many of us could deal with. But I would love to hear Dr. Bhagat's view because he actually went deeper in for AHPI.
Sir, Dr. Bhagat?
Yeah, thank you.
Yep.
You see, I studied the problem from all India level. And first, I would like to answer Dr. Vijay's question. Is it possible to track the source of oxygen, industrial or not? My answer is no. It's just not possible that you will be able to track from where the hospital was getting oxygen. Because if you see the manufacturing process of oxygen, it is the industrial oxygen which is supplied with certain certificates to the medical division, and a small percentage is only was converted to medical, but the demand jumped and the supplies were increased, rightly so, by the authorities. So this was there. The problem of Delhi, first I would like to mention, what happened was that as the demand jumped almost 5 to 10 fold suddenly, the major hospitals, when they faced the liquid oxygen crisis, they raised an alarm And after that first alarm, they never faced this problem. That means all the hospitals which could have the pulls and pushes, they could manage it, except for the Batra hospital and Shanti Mukund, which faced this problem, because Shanti Mukund was not that pushy. And I don't know what happened in Batra, but the liquid oxygen supplies to all these hospitals were well maintained. The problem came for the smaller hospitals, which are dependent on the cylinders. The cylinders, what they did was they took charge of all the filling stations, the government authorities, and they changed the vendors for almost everybody. Like my vendor was just 3 kilometers away. My vendor was 3 kilometers away. I was shifted to a vendor which was 20 kilometers away. And I had to stand in queue for 8 to 10 hours. And I personally saw this process. I went deeper into it. I saw the process, and it was really ridiculous. It was only after a lot of pressures on the authorities that they changed the vendor to somewhere near the hospitals. Like Pushpanjali Hospital from East Delhi, he was given a vendor in Mayapuri. That is almost 25 kilometers. So this is how these people were managing. The conclusion is that the supply chains were disrupted, existing supply chains were disrupted by the authorities without understanding the process which was there. So suddenly stepping into the process and taking over without understanding what was the existing system, that was one of the major factors. Of course, the demand jump was definitely there. So I also, what I did was I stopped admitting the patients for a certain period. For 5 to 6 days, we refused to take patients which were requiring high oxygen. They were requiring high oxygen volume. Leakage, definitely we found. Oxygen audit we introduced, we discussed with various people, and there was leakage. The drop in pressure, which was mentioned by one of the speakers, yes, that is expected technically because the pipelines are not designed. You may increase the terminals at the endpoints, but unless the supply lines are augmented by the diameter of the tube, this drop in pressure is bound to be there. And the evaporators of liquid oxygen, they are also going to face. So that is also a learning thing for all the major hospitals, that you have to take care of the evaporators. Are you going to? Even I had a manifold. I had anticipated this problem of oxygen to some extent, but not to this extent, that I had a dual supply system. I was generating my own oxygen, that was about 28 cylinders per day. And I was using some cylinders from outside before this crisis. But when this crisis happened, I was requiring about 120 cylinders from outside. So that much volume was difficult to match. So one day, particularly, I was not having any supply from outside for almost 30 hours. Since there was no supply, only my own generation was able to maintain some flow in the pipeline. The pressure, of course, dropped. Since the pressure dropped, the ventilators were not functioning. I had to mobilize my staff to go for manual ventilation of these patients. Fortunately, none of these patients died, but we were able to manage these patients till the supplies came next day. And now the issue was, is the distribution of oxygen to be managed by push and pulls, or is it by the requirement of the systems or hospitals which are there? So fortunately, Delhi failed, that they were supplying liquid oxygen to major hospitals, all the branded hospitals, big hospitals, and they refused to supply to the smaller hospitals. The crisis was there. I've been on the various groups. I've been seeing various SOS which were there. But there was another point which was creating the problem, that the NGOs or various so-called selfless workers, they were diverting a lot of oxygen to give it directly to the patients at home. Now this put additional demand on the system, that from where this oxygen was coming. Then I dug out, most of these people were getting oxygen from Uttarakhand and Himachal, which was not in the loop of the government. So they were getting it from there. But definitely the single cylinder user were crowding these vendors from where we were getting our oxygen. So they were creating, just imagine a crowd of 200 people standing at the gate of filling station, and we had to push our truck inside. It was physically impossible. We had to wait for 6 to 8 hours for police to come to allow the trucks to go inside and get the filling done. So this was about oxygen. Definitely disruption of supply chain was one thing, change of supplier was another, and oxygen audit is something which everybody has to note, and you can cut down consumption of oxygen by 30%. There are ways, we had given that in the white paper. At the same time, AHPI has sent out a Google questionnaire, whatever your experience of this is, so that we can sum it up and prepare a document later on for everybody to use, how to manage these crises. So that is about oxygen. Rest of the things as we take up, we'll go on that.
Thank you very much, sir. I think you gave a very comprehensive outlook on the oxygen issue. I think one thing we learned is there is need for you have to do the regularization of the supply chain and also do the control. I think the government controlled or somebody has to control this kind of movement. And that's what I think it's from your point. I think as Madam said, we should take up the next point. The other point which everybody faced during this crisis is the manpower issues, be it doctors, nurses, or other paramedical or any other support staff. We had issues, not only that not enough strength was not available, but also people fell sick. They were not available for the service. And even people coming for the duty were not to their the best ability. So there were many issues. I think in this issue, how each one of your leaders faced this crisis and were able to overcome during that hour of crisis. Can I request Colonel Dayananda, sir, because he's coming from Mysore and he's running a large teaching hospital, which is a 1,200 bed hospital. Sir, your experience on this?
Yes, sure. So firstly, thank you for the opportunity. And just I wanted to highlight on this HR, there is a human resource business. So if you imagine that all the doctors, the day one onwards, they will start working in the COVID wards and everything will be, streamlined. It is not so. There is a huge amount of reluctance and there is a huge amount of, hesitancy as well as not wanting to do this duty. It starts off with that somewhere in the month of April, May. Last year it started off. So initially we had a lot of sessions on the guidelines to how to treat and especially the personal protective measures, how you have to look after yourself, because there was enormous amount of scare. Nobody knew, nobody understood the disease process, nobody understood how it spread. So it was so much so that doctors, probably the most easily amenable or easily who voluntarily took over their responsibilities is the nurses. We had huge amount of problem with the doctors. So later on, slowly we conducted a lot of sessions to them in terms of what is this disease process, what are the guidelines, and also we had our psychiatric department continuously motivating and talking to the doctors how we need to address this, and it is a national calamity. We need to jump into it and do the job, what is expected of us, not being volunteering, doing that, it's not a good this thing. So it took about 2 to 3 weeks for us to ultimately convince the doctors, especially the senior lot, because the senior lot is more reluctant. That's what I found. Because younger ones, the house surgeons, the postgraduates were by and large were okay with that and they wanted to work. It was the persons, it is the faculty members, we had a problem with that. So we overcame that. And second big problem was all our staff comes from nearby villages. The travel problem is a huge problem. They are stopped at each various points of time. In spite of showing their hospital passes, it becomes difficult for them to travel. So we ensured that all these people are housed in our own hostels nearby so that they need not to go home and need not to infect their own. There was a scare. They could infect their own family members. That was stopped. And also the doctors and especially the postgraduates who are married and having young kids, they didn't want to go home. So I said, okay, if that is the case, we facilitated, private wards. About 20, 30 doctors were kept there and they were doing their duties as well as going back to the room. After a week of their break, they will go back to their home. So this is again one more issue that was faced by us. And the third was a lot of our students, postgraduates are all staying in various apartments as PG accommodation. They were not let into once they started, when they knew that this person is working in a hospital, they were not allowed into their apartment. No, we can't allow you. You are already working in a hospital elsewhere, so you might infect us. So a lot of hurdles were there even for our staff to be brought back to the hospital. So various ways were there, but ultimately that was all seen to it that was all sorted out and things were in place. But most importantly, I would like to highlight, because a lot of hospital owners and CEOs are here, there is a huge amount of governmental interference First of all, they can't manage the affairs, and secondly, they get into you and they will tell you to dictate terms how to do it and what not. Now we have reached a stage. Remdesivir, each time we have to write to the nodal officer. For oxygen, we have to write to the nodal officer. That is the status we have reached in our Karnataka especially. And the rules and regulations are changed very often. We do not know what to do today, and next day there is a new set of this thing. Now, like we have procured vaccine, but we can't give it because the government says only 45 and above. So a lot of things are there. When we probably meet next time, a common agenda need to be made to make aware the government, state governments, how to go ahead in future, because they have messed up enough now. All private agencies, though they use the private agencies, but there is no acknowledgement, there is nothing. They will come out with new rules to tell you tomorrow what to do. So what from this forum I would expect is that we should formulate something for at least for the next wave of this thing that is expected, maybe September, October, November, I do not know. So we should say that these were the constraints of our this thing, and please don't meddle in this. What you need to do is partner us. Because if you see, amongst all the states of this country, the Karnataka has got the highest number of private medical college hospitals. 48 medical colleges are there. Besides government, about 10 or 12 government medical colleges. Can we not get together and do a fantastic job? We are struggling, and there is space, and our hospital is the largest in Mysore. We had almost 417 COVID beds we have. So somehow it has been very mismanaged, and smaller hospitals are stressed. They go to the 100-bed hospital, you give 50 beds, you give this thing. They can't do it. They have no manpower to do it. They can't handle this at all. So out of maybe our hospital and 2-3 other hospitals, others are struggling in the sense that they can't manage. They can't manage COVID patients. It's not possible for them. So that is also a very important issue that to be raised, that you have medical college hospitals all over Karnataka. In some places we have medical college, 5 to 6 medical colleges in one city. So if you can't get together now, I do not know when we can collaborate. So we must do this. I think Dr. Who's the president of FANA is also here. This can be proposed from his side rather than stressing the small hospitals in Bangalore, Mysore, here and there. This is one point I had. And this is a very good effort to connect each other so that I understood what all went around in Delhi. It's, I mean, very educated to understand this. Plus, I would like to highlight also that in nearby district, about 40 kilometers from here, we had about 16 deaths because of the oxygen was not supplied to that government hospital. So I was, from that day, we spend sleepless nights whenever our oxygen level goes down, because it's very scary. Government hospital is fine. They go to court and there is some inquiry committee. But when it comes to a private hospital, it will be very, very scary for us because the action and punishment is very swift for us. So this again, we have done a lot of measures. Maybe in the next meeting, I'll tell you what all we are doing for oxygen because it was discussed enough. So this is what I would like to stop now because there are other members too. The manpower, especially the clinical, the doctors and this thing, manpower, motivate them and to get work is really difficult. I don't know whether you people have faced or not, but I have faced. And now we have reached some level of understanding and kind of, things are going on. But believe me, it's very, very difficult. The best the staff that is very forthcoming in this thing are the undergraduate, the residents, the postgraduates, and the nurses. So I just wanted to highlight that because not many medical colleges are here in this group. Thank you.
Thank you very much, sir. I think it was very learning experience from your side. I think we learned that there was also more problem from the clinicians and especially senior clinicians. And one thing we learned from Dr. Dayanand's issue was the government intervention. I think government intervention, I think most of the people have faced. I wanted to now go to Dr. Upasana Arora. I think I was told that she's one of the front-end leader who's always interfacing with the government. Madam, can you throw some light on the government intervention in the COVID care, how it's affecting the private hospitals?
So good evening, everyone.
Yes.
Fortunately, in my hospital and in UP, there was no crisis of oxygen. So we have not faced this oxygen crisis. And even I was able to help other hospitals who were suffering from this problem. So when another CEO called me for some help, so I could help them. So But if you say that government intervention, naturally in my state also government, they have issued so many different kind of protocols, so many different kind of notices that you have to follow this, and likewise remdesivir is not with the with the hospital. It will be available with the nodal officer. But fortunately, I never faced this problem in my hospital. We were getting remdesivir and we were getting oxygen. Only problem was to motivate our staff, and for that purpose I was, we are treating them like a family member. We were just giving them CAHO, juices, good nourishment food, so they should not feel like exhausted, because we have started with 100-bedded hospital for COVID. We have given a separate building. But then load was increasing and we were supposed to increase our bed strength. So we have given 250 beds for this COVID. So when you are increasing your bed strength, then you are supposed to involve more staff also. And it is difficult to, to make them agree that they have to do, because, everybody is scared. So just to make them relax, we have tried all type of, emotional, spiritual, all things. And just because of all these things, that staff was very much relaxed. And fortunately, this time in second wave, because all my staff was vaccinated, I hardly find that only 10 or 12 people got sick. Otherwise, everybody was fine. In first wave, it was very difficult for us to manage because lots of doctors and staff become sick. So this time, most important, and I would say the most difficult part for a hospital was to select a patient. You have only one ICU bed, you have only one ventilator, and you have 4 or 5 patients for ventilator or for ICU bed. That time it was very difficult to choose to whom we should provide this bed, because everybody wanted, please give it to us. And so that time it was difficult, but we have done some, trial system that who need more, or some young patient. Like there was a 24-year-old patient who was actually sick, and he was supposed to get a ICU bed. And there was another 94-year-old patient. So that time you are actually hospital staff, and your doctor is confused what to do. So these kind of problems I have faced, but by the grace of God, we have not faced this kind of problems that through government areas, because we have a good relation with everybody. So all the administrative officers were helping us. Even district magistrate of my district was admitted with us. All officials were admitted with us. So I have not faced such kind of things. But same time, this was a very bad time. And I must say that all healthcare workers, they were actually exhausted, and we are still trying to prepare ourselves for third wave also. When we need to prepare for PEDS. So pediatric department, we are now strengthening, and now I think that we have enough time to make ourselves perfectly ready to face this challenge. Thank you, Dr. Naren.
Thank you very much, madam. I think your feedback is excellent. I think we are preparing already for the third wave. Dr. Dilip Chavan had a point. I think he wanted to discuss about the HR issues. So Dilip Chavan, you want to make a comment on this HR issues, because you are said you wanted to discuss about the staff issues during the COVID.
With the clinicians and nurses, we had faced a problem for cafeteria, just like cafeteria. Kitchen also, cafeteria service is also very important for any institution. So I think first when I remember this 21st March 2020, when first COVID patients came in the hospital. I think within 15 days, more than 100 staff left from our hospital. So that time we have more than 100 patients, more than 100 normal patients we have admitted over there. So we have faced the biggest problem to serve the food. So just I wanted to share the one thing. We have motivated my nurses. We have motivated my nurses to work in the kitchen. We have for that I came out from my air-conditioned rooms and motivated the nurses. The nurses cooked the food for the patients for, I think, more than 15 days. So that's my view. If any institution wanted to come out from this type of services, so we healthcare leaders to come out from the air-conditioned room and work with the smallest employee of the hospitals. So they can develop a faith in everyone, the institutions and head of the institutions. So this type of problem we have faced, and I shared my resume.
Thank you very much, sir. I think it was quite motivating for the staff during this. The leaders motivating the staff during this crisis is very helpful in fighting the disease. I think Dr. Sunil Sagar wants to make a point. Sir, you can go ahead.
What we did is that we faced two things. One is that on manpower, I could go to the social organization, right? Lion Club, Rotary Club, Gurdwaras, and other things to send their volunteers. On another step, we could put over, back office staff to do some sort of work which is not that technical, taking the oxygen levels and other things, making notes of the thing. So that helped. Another thing which we'd like to place on record our gratitude to our fellow hospitals is when they saw me in a problem, most of them, they came forward. They came forward, we will send you the oxygen cylinders, we'll send you other things, other help. So that was unique in my career of 45 years over in this industry. I saw for the first time when your fellow hospitals, they are coming to your rescue. They sent me the Bollywood, the industry. The Sushmita Sen, actually the day I made a appeal, the next day she sent me few cylinders. And many people. I think that when we were talking about, you ask for, people are willing to help. They actually help you. They actually help you. And I think this was a unique thing, which probably, and then we requested, there's a lot of pressure on the nurses. When most of the medicines, from whether they are the high-end antibiotics or the steroids, the other thing, they were required to be an intravenous. We could request our doctors that if we can change that from something from intravenous to intramuscular or the oral. So the difficulty in putting IV is cannulas breaking and cannulas getting displaced and other things. So we got a cooperation from our doctors also. There was many things which probably they came and the people helped, and I was so moved that I would like to place, and I have not that they helped, even whenever they needed any help, my hospital was willing to come forward to help. So this platform or place there where we come together, we know each other, we get to know each other, and that gives us a feeling of helping each other. So this is what I wanted to place on record through this platform. And maybe if it is possible to, I've been doing this, my staff, and so much so, sir, basically few of staff, they said, okay, I will bring my brother, I will bring my sister, I will visit all those. So this sort of feeling wherein you say that, okay, we own our patient. We owe to patient, we own our patient. This is a great feeling. I would like to, place my thanks, sincere thanks to all of them through this platform also.
Sir, I agree with you, sir. I think community participation is very important. And if you can take the help of the community in providing this kind of, overcoming this deficiency, and it will be excellent.
We put the food table, we put this thinking, you come, whatever you want to time, you have a nourishment, you have snacks, your cup, coffee, a biscuit, we put trolleys everywhere. Whenever you want.
Yeah, so Narain sir.
I think, yes, madam, please.
Yeah, we do have Dr. Nagasubramaniam waiting to share his thoughts.
Yes, doctor. Yes, sir, Dr. Nagasubramaniam from Fortis Hospital in Bangalore.
Good evening to everybody, and nice to know about the various experiences each one of you shared. I just have one thing to ask all of us. Why, as healthcare workers, we need to be always reacting and being hunted, what is the accountability of the government agencies? Like, for example, in this 2 months in the field working at ground zero, what I have seen is the IAS officers coming and asking for the beds in the hospitals. Like, many of you know what has happened in Karnataka, especially in Bangalore, where 75% of the beds has been taken from the private sector. When I was going through all these things, I just was thinking a simple solution would have been, in Bangalore, there were 18 medical colleges. If the government had taken, each medical college had 1,000 beds. If they have allotted 500 beds for COVID work, that means 9,000 beds could have been got ready. And out of which 10%, if they had made as an ICU beds, and 30% as HDU beds, and remaining 60% as oxygen beds, and bring in an infra wherein they could have given the oxygen connection, and they have infrastructure, everything was there. So 9,000 beds could have been arranged in Bangalore in a simple way, a simple planning by the so-called the fraternity of administrators, the IAS officers, who wield all the power. They failed the whole city. The Bangalore has got the highest number of cases and the deaths happened. Who is accountable for that, ma'am? Why we as healthcare workers, we are always reacting and we are sharing our experiences. Oh, we did this, we did that, we managed like this. Who is holding the accountability of those people who had power? They had everything to change, but they did not do it. And we are running from pillar to post. I asked the IAS officer who came, is it a crime for admitting a private patient who is coming to our hospital, to the footstep of our hospital, who is sick? Why that only the patients referred from the government has to be admitted? We are ready to admit. We are not saying no. But you are saying that how you can say only that you have to admit that patients. These are the people who had been traditionally coming to the hospital. Now they are requiring beds. They are sick. We are not able to help. Just because of these government, the local government authorities, the way they think and the way they try to snatch away their shortcuts. Nobody discusses this. This is the sad part of it. As an organization, as a CAHO, I would request that we should discuss all these things and put up protocols and tell to the government agencies that this is what you have to do in a crisis.
Certainly,
but now again we are trying to do things. We are trying to react at a very low level, ma'am.
Yes,
this is not going to help. Next year when it comes,
let me
just,
sir, we fully understand your
Yeah,
emotions. Let me put up 1 minute, Vijay sir. Let me just put up a couple of points. I am not a medical doctor, but I have come into the industry. Industry has accepted me, adopted me. Last 13 years, let me tell you, this kind of a setup, this healthcare industry, the problem is that we are not together. This will never happen to the lawyers. This will never happen to the accountants. This will never ever happen to the engineers, which is my own fraternity. Let me be very honest with you. The whole problem is that we are not together. We are a divided lot. We don't want to listen. We don't want to share best practices. We have too many associations, too many organizations not joining hands, not ready to join hands also. So this country, we cannot change if all of us are not going to sing the same song. And the time has come that all of us sing the same song, irrespective of whether you are in Karnataka, we are in Tamil Nadu or Kerala or wherever. So it is time for us to come together and raise our voice. And that's exactly what we need to do. And over to you, Vijay sir.
I'll just add, you raised a very important point of us coming together. That's an effort that we are doing. I would also say that crisis highlights the bankruptcy of the leadership in each organization. And the government or the bureaucracy is no exception. So their bankruptcy of their ideas, etc., is highly exposed during this period. However, all of us have a certain amount of limitation to bring about a change. Okay, and my feeling is that I remember the famous saying, God give me serenity to accept the things that I cannot change, courage to change the things that I can, and wisdom to know the difference. And here I am only looking at the courage to change what we can. And together, if we come, I am sure that what Dr. Naga's emotions also, yes, we may be even able to address that. However, we will not be able to address it merely by our emotional outpourings. But what we need is that today, first of all, let us try to collate lot of our data in relation to what is happening. We need to also take media onto our right side to project the right kind of things and move on. I think you have made a very important, I think your emotions are stirring us up to move at a much greater pace. And in certain local areas, we have been acting towards that. Legal options are another very, very important option for us to explore, to block or to counter the, I would say, bankrupt ideas of the bureaucracy or the politicians. But what I'm saying is, what will happen is, we will want probably some of us again in another forum to discuss as to what can be done in that issue of advocacy. And that's where we believe that our sister organization, AHPI, they are our leaders in advocacy. We are trying to go more into the vertical division of what can we do. For example, I am sure that majority of the smaller hospitals or even the medium hospitals do not know what kind of oxygen supply sources, alternatives are there for future. You see, everything does not have to be band-aid. There are huge, huge issues that we have to together cross. And I will, therefore, I feel that this forum can be the catalyst for that change. Thank you.
Certainly.
Sir,
Thank you,
Dr.
sir.
Harish. Dr. Harish has a point, I think, in this regard. Dr. Harish.
Yeah. I agree with Colonel Dayanand what he told. Since we run a large hospital of 800 beds, as one small issue I wanted to highlight was our patients themselves adjust the oxygen at times. That was a very big challenge for us. Patient would increase, decrease oxygen at his whims and fancies, depending on his comfort.
Correct.
Then coming to the manpower, Colonel Dayanand explained it very well. But one other challenge we had was, ordinarily during non-working hours, patient gets admitted to the emergency ward. Here we get patients admitted to all the wards 24/7, and that was a big challenge. And second was, when we were at the peak occupancy, we could not differentiate male and female. We had to put everybody in every ward because we could not accommodate them. And the third challenge we had was the continuity of care. Every 6 hours when the shift changes, the day changes, the continuity would not be there. So we established about 7 or 8 war rooms for every 60-70 patients, and people who would not go into the ward, that is the senior faculty, would man it from outside so that the continuity continued in the care of the patient. I just wanted to make this point. Thank you.
So, Narendra, can I ask one question, and if or your participants can answer? How many of them tried to use technology to counter some bit of the HR issues? So, how have we used whether telemedicine or any other aspects of technology for even communicating with the patients? Today, one of the biggest problems that we keep hearing from the patients that they are not getting a kind of a feedback. So any structured mechanism of using technology to overcome the HR issues?
Sir, if
any
you
examples?
Permit me, Dr. Vijay, if you permit me, can I?
Yes, yes. Narendra, please.
Yes,
go
madam.
ahead.
Yes, madam. Dr. Prasanna, I think.
Actually, because when patient is in ICU, so half of the time attendants or relatives are asking for, what is the status and all. So what we are doing, we are just giving them a video call. There's a time fixed and with some tab. We all the patients who are in the position of talking, they are talking to the attendants, and some who cannot talk, my sisters are just showing their faces and explaining their status. And same time we are providing this teleconsultation also to because lots of fear is also there. Somebody who is not well, he doesn't want to come to hospital. because he has this fear that I can get affected if I will reach to hospital. So we are providing these kind of services, and actually this technology is really very helpful. And I am thankful because Dr. Vijay is always very much, in favor of new technologies. Thank you, sir.
Yeah, Dr. Sandeep.
Good evening, everybody. Nice to be on the forum. So I had one submission to make over here is, I agree completely, the sentiment is the same, especially because of the oxygen shortage. We encountered a lot of heartburn, a lot of pain at the time when we had that oxygen shortage. And, we even put out an SOS to start a shift out process for the patients. But anyway, somehow we could hustle and rally all the supports to bring in the oxygen at the right time. But my thoughts at that particular point was that as we are initiating this SOS shift out process, we'll be busy with the patients and the counseling and the movements from within the hospital. If there could be a sort of, region-wise or at least city-wise or city region-wise organization which could help from the outside to the shift out process, because ambulances need to be arranged, other hospital beds in other hospitals need to be arranged. So simultaneously all this process needs to be initiated. Of course, in one of our medical college hospitals itself, the oxygen ran out and they initiated this entire shift out process. So what you could see is a hospital who is initiating a shift out process is all alone. I mean, they have to deal with the crisis of the oxygen. They have to deal with the emotions of the of your own emotions, the emotions of the people, the emotions of the patients, the emotions of the relatives, phone calls coming from all 10,000 directions. So I mean, I think it's a very sensitive point at that point when we're initiating a SOS process. And if we have an organization centrally outside whom we can reach out to, and the government is not bothered about this, because the government doesn't see this as a problem. I mean, this is your problem. This is your problem. Your hospital, your patient, your oxygen, your problem. Your death, your problem. Okay, so this part is not going to be looked after by the government. This has to be looked after by us itself. So if we can set up a central agency where from a central point like a war room, which will help us out in this shift out process, identify 2 beds there, 2 beds there, 2 beds there, send in ambulances, and then, from inside the hospital, we work out to transfer out the patients. So this is my submission to this group.
I think it's a very excellent point to wonder about, because particularly the private hospitals, when they have disaster, as you rightly said, nobody is there. And it's us, yes. So maybe it's a thought process for even Dr. Gyani. I see his presence here, Dr. Gyani, Joy Chakravarti, and some senior leaders of HPA also here, who can all work together. And for your words, Gyani sir.
The point is that I salute to all the 35 or 40 leaders who have assembled today to share their experience, number one. I think there have been, mistakes done. But, in the crisis time, mistakes will happen, let me tell you. Because that is a war kind of situation. And now we can always introspect, what happened? Somebody could have done like this, government could have done like that. So this is happening. For example, let me say steroids. The AIMS came 3 days back, steroids have been used and used, that was the mistake. But, we should have done that months back. After full damage done, now we are saying steroids were used indiscriminately. Similarly, somebody will say that antibiotics were used without anything. Management also, there have been problem, crisis and leadership, political, bureaucratic and medical. Everything has happened. My request now is that CAHO is the platform. This what has been organized today, we have to organize few more, not few, so quite a few more. We will collect this information, because forget about wave 3, any pandemic in time to come. If we can collect really in point by point, not a paper like 10 pages or 50 pages white paper, no. Simple bullet point, what has gone wrong at the government level, what has gone wrong at the bureaucratic level, what has gone at our own level. I think that will be a good document from us, and I think this can only be done by the CAHO, because what we call CAHO is quality organization. and the kind of leadership which I am seeing today, and of course there are plenty more who are there. So I think heads off to this initiative. Please organize few more of this kind, and we must come out with a good document in time to come.
Thank you very much, Gyani sir. Well taken. Let's all work together and put all our thoughts together, because otherwise, after 5 years, we'll be speaking the same thing. So it is very important that we interrogate and put it all together as recommendations and try and see that it's all done.
Can I take half a minute?
Go ahead,
Yes,
Seema.
yes,
ma'am.
yes, Seema. Yes.
Yeah. I just have to say that
Dr. Seema is the leader of our diagnostic section for all of you. So if you have your labs accredited, Dr. Seema is the person. Over to you, ma'am. Yes.
Thank you, Dr. Lalu. I just wanted to say that no one talked about the labs and the crunch that we are facing. We are facing not only a crunch of manpower, but also a crunch of availability of reagents. And whether the doctor is going to continue with steroid treatment or whether he's going to reduce it depends upon the result of our immunological parameters or our IL-6, ferritin, and HSCRP. And we have had to really, really work hard in making sure that our supply line, which had suddenly boomed, our requirement had suddenly boomed beyond our supply lines. So we had to work really hard to make sure that we did not suffer, the patient did not suffer on that score, that the test was not available or that the report was not available on time. And somehow in the second wave, we had many more of our staff who actually went down with COVID. And then managing that was quite a challenge, but it was done. So in a small way, we too are responsible for patient care, and we try our best. But yes, having a supply of the reagents and having a supply of those basic things are very, very important for us.
Ma'am, not in a small way,
Seema,
very, very big way. Yeah, Vijay sir.
I'm saying that this issue of, I would say, in this second wave, we could see one thing very clearly was the overuse of medications and the overuse of investigations. So we will definitely come out with another kind of a concise paper, which will be circulated to all of you. For your viewpoints, we want to make certain things very clear that we all owe this responsibility, that this issue of getting right on day 1 or day 2, people going and getting themselves a HRCT or getting their IL-6 or D-dimer. I mean, people have heard about these names, which were only to give prognosis for patients who are admitted in the ICU kind of a setup, now are being used in home care just on day 2, day 3. So anyway, this, Seemaji, thank you. It will be definitely because we have large issues. And we will, that's why, take this forum, these people, sir, when we communicate with you, we expect that you will just give us 5 minutes and respond back with your active, I would say, yes, no, whatever you feel, just kind of come back to that. So that's what I would like to add. Over to you, Lalu.
Yeah, thank you very much for that. Yeah, thank you so much. This has been a brilliant time. Honestly, let me tell you, it's like, not a virtual meet. It's as though we are all meeting in one place in a meeting room. Amazing feel, and thank you for taking the time off. So it's a great day for us having all of you. So thank you very much for taking your time and for joining us. We really look forward to having many sessions, and because this is the key. This is the pillar of what we do. Thank you once again. Have a great evening and stay connected, stay safe.